So today we will talk about MRCOG Part 2 exam, how we can prepare the best for this exam, which is considered the most challenging step to be a member of the Royal College. In the same time, also it's the most challenging, but can be the most useful. Because I think, and this is always my opinion, that studying for MRCOG Part 2 will be mostly the last time in your life that you study multiple months for a specific exam. And this can be the last time because after that already you had a good amount of knowledge. All just you need to do is to keep yourself always up to date. But to have bulk studying, this is it. So please don't spare time, don't spare any effort for this exam. Don't listen to anybody telling you, just you will solve some recalls, you will enter the exam, you will find the recall questions, you will answer and you will pass. This is not right. This is a trick. This is not right at all. And RCOG is not stupid. That's why they try to decrease every time the amount of recall questions. Because they know that doctors try to study just recalls and enter the exam. It's not fair that somebody studied well and somebody else just studied some questions and answers and both of them pass. This is not fair at all. And even if this happens sometimes with some doctors, please don't fall in this trick. Because as we said, if you pass this exam without good studying, you lost a very important advantage in your life, in your career, in the care you are giving to your patients. I believe that after studying MRCOG Part 2, your attitude and your level of knowledge, your self-confidence, all of this will be much different than before. So it's not just an exam, not just preparing for an exam, you will do a big improvement and you will do big change into your career and your life. So let's see how we can prepare for the coming exam, which will be in January. Some of you may be not preparing for January and maybe preparing for July. Still, you will get benefit also of this meeting. And I'm preparing, inshallah, that after having this orientation session, that we will have a small scientific topic to give benefit for all of us. Okay, so let's start to talk about MRCOG Part 2, its preparation and its exam. Okay, so already all of you, alhamdulillah, passed Part 1, which was mainly a basic exam including physiology, anatomy, bio, statistics, and these things. And partially, this exam is also a clinical one. But Part 2 is the main bulk of the clinical knowledge. To study Part 2 well, you will be required to study all UK guidelines talking about gynae-obstetrics. What is the source? Mainly we talk about NICE guideline, Green Top guideline, because Green Top guidelines are published by the Royal College, which is the authority that will give you the exam. Also, talk articles, which are coming from the Obstetrician and Gynecologist magazine, which is also published by the Royal College. And this magazine is considered an endless source of knowledge because every year there are 4 issues. In every issue, there are about 8 to 10 reviews talking about all aspects of our specialty gynecology. So you have to be updated. And alhamdulillah, in my course, always I summarize these talk articles. And even if you are not in my course, some talk articles, I start to do that soon. That I do video summary on my Facebook account. So I will write you at the end of this meeting my official Facebook account so you can watch the videos there. Okay, so this is Part 2. Also, you need to study guidelines talking about infection from BASH, talking about contraception from Faculty of Sexual and Reproductive Health, talking about HIV from PHEVA and many other sources. Scientific impact papers, many sources for this MRCOG part 2. Very big course. That's why here's the advantage that this will be concise, summarized, and only in one place. So you will not consume much time in searching for the source of knowledge. Okay, everything up to date, inshallah, will be present here in our course. After passing part 2, which is the most challenging, as we said, then you go to have part 3, which is more practical exam. So we can assess how you are dealing with the patient and how you can apply this knowledge you got from part 2 exam, how you can use it in the communication, in the counseling, and the discussion with the patient. Okay, so part 1, part 2, then part 3. Okay, what if a trainee is working in UK? How he needs to pass this exam? The training matrix in UK, in NHS, is made of after being graduated from the medical school, you become foundation year 1, which is general year of training in all specialties, medicine, surgery, ENT, ophthalmology, and others. As foundation year 2, you become more interested into one specialty. For example, foundation year 2 can be concentrating more in gynae. After that, you start the specialized training years, which are made of 7 years. And these 7 years are divided 2, 3, 2. Why they are divided like this? Because to pass from ST2 to ST3, you should pass part 1 MRCOG exam. And to pass from ST5 and become ST6, you should pass part 2 and part 3 MRCOG exams. So doctor, you mean that all trainees in UK, let's talk about ST6, all ST6 in UK, they passed part 1, 2, 3? Yes. So it's a basic exam, yes. It's not the most complicated exam all over the world. It's a basic exam. Okay, and we will know how we can deal with this exam because it has a specific, because it's not just having knowledge. Okay, because I may ask you about what you will do if a patient has so and so. And I am asking you, and you are at the level of ST5. Your answer, of course, will be different if I am asking ST1. And will be different if I'm asking ST7. The exam is assessing you as a competent ST5. If you answer as if you are a consultant, although your answer is scientifically right, but your answer is wrong. Because I am asking you as ST5. I am assuming you are a competent ST5. Don't answer as a consultant. And in the same time, don't answer as ST1. So it's not only a matter of knowledge. It's how you will answer according to the expected level from you. So if I am in part 3 exam and he's asking me about a patient, I said the best things that can be done. Your answer is wrong. Why? Did you answer as if you are ST5? No, I answered because already in my country I am working as a consultant. I am sorry, this is not what is required. We are assuming that you are ST5, competent ST5. Because competent ST5 will have the exam, will pass, and become ST6. So one of the keys in this exam, know what is your level. You are a competent ST5. Okay, after finishing all the 7 years of training, you receive a cert called Certificate of Completion of Training. After that, you start to be subspecialized, to have the advanced training subspecialty modules, to be a consultant in one of subspecialties, like consultant fertility, consultant oncology, consultant endoscopy, and others. Okay, so where is your level now? You are same like ST5, who want to have part 2 exam and also part 3 to become ST6. So this is your level. So how we can pass this exam? And I acknowledge it's not a simple one for multiple reasons. Number one, its curriculum is really very big. In the same time, this curriculum is expanding. In the same time, the curriculum is being up to date always. So every few months, you find a new guideline, a new green to guideline. And always you will find new nice guideline. And every year about 30 to 40 new review coming from the magazine, which is top magazine. So you should be up to date with all of this. Even after passing the exam, you should be up to date because your colleagues are expecting a specific level knowledge of you. If you just say, all I need, all I want to know, I just want to pass the exam to take this certificate that I am a member of the real college. Okay, what will happen when your colleagues ask you? Because you are the member of the college. They ask you and you don't know. They ask you, you don't know. Although you passed the exam, but you know in yourself that you didn't study well. This is not an easy thing. Okay, it will be like learning all over your life. So please study very well. So after having this exam and the certificate, inshallah, you will be a different person with more knowledge, more up to date. Okay. So how we can pass this exam? It needs hard working. If you say, I passed the part one from my first trial, I studied only 2 months before the exam. Okay, this is not the same scenario in part two. Part two needs hard working. From now, you start hard working until the exam in January. So this exam needs 6 months of study. 6 months. And not light 6 months. They can be slightly light in the first 2 months, but after that you start hard working. So please don't take it easy. In the same time, it's not so difficult. And the amazing thing in part two, that what you study, you go to your hospital next day and you apply with the patient. You will be more proud and more self-confident. Okay, so what you study, you will apply. Another thing, please don't walk in this way alone. It's difficult alone. Okay, you should be in a group. Okay, at least 1 or 2 more study partners so you can support each other psychologically and scientifically. For example, you can agree with your study partners that this week we will study so and so and so. So you encourage yourself and you may say, I didn't understand this point. Another colleague can explain it to you. And we believe that the best method of learning is to teach. Because when you teach others, you remember 90% of what you taught others. If you just read, you remember only 10% of what you read. So try to teach. Be in study group, not alone. So when will be the coming exam? It will be on 17th of January. So it's after 6 months from now? Yes. We will take 5 months in the longer course, then the last month will be the crash course, inshallah. To summarize everything and solve many questions, many recalls, so we can have an idea about how the exam looks like. Because yes, some questions can be repeated in the exams. Although it's not a big percentage, let's talk about 20, maximum 30%. Okay, but it's still important to study them. Okay. All who are planning for January exam, please, you have to open your RSG account and in book an exam. Then MRCG2, you should press on this hyperlink, expression of interest. So the college knows that you are planning to have the next MRCG exam, so they can try to find a seat for you this exam. Because you know, finding a seat is not completely easy. It has some challenges because of the low availability of having. It's easier now than before, yes, but it still needs that you prepare well and you should book early for the exam. When the booking for the exam? Booking for the exam will start in 14th November. Our target, all doctors planning at the exam in January to secure a seat, please book in the first minute. When booking to the exam opens, usually it opens at 9 or 10 a.m. UK time. So book in the first minute. So you have the freedom to choose among different exam centers in your location. Okay. Although the booking will stay open about 1 month, but we need to book in the first minute. When I had my exam in 2016, I booked in the last day of this month. But at this time, always there was a place. But now, I should book the first. Okay. After having the exam in 17 January, about 1 month later, the exam result will be published. And always I say, whatever the result of the exam, you got benefits, you studied, you improved yourself, you improved your knowledge. You are giving now more better care to your patients according to the most recent British guidelines. And you know that there are multiple schools in gynae and obstetrics. British school, American school, Canadian school, European school. In my opinion, to get yourself out of this dilemma, take one school and walk through it to the end. And this is what I do actually. I study well the British school. I don't care what the Americans say, the Europeans say, because I trust in the British school. Okay, of course, it's not perfect. In some topics, you may find American can be better. Okay, but I prefer to take one school to the end. So if in my country, I will give my patients a care similar to what NHS does in UK, I'm proud. It's very good. Okay. So this is a performa of expression of interest. You will write your college ID number, your email address, first name, and your family name, confirm, then submit. Some doctors, when they try to do this performa, it doesn't submit. Why? Because there is patcha. Okay, some browsers prevent this patcha from appearing, which is security check. So if it doesn't open from a browser, try from another one. Not from mobile, okay, try from computer. Not opening from computer, try from mobile. Until it works, you will find the patch, then the button submit will be active. Please, if you are planning for January exam, do it today, so you don't forget. Because many doctors, oh my God, doctor, the last day of expression of interest was yesterday. I forgot to submit. I'm sorry, you cannot find that list. They will not send you the link to book the exam. So please do it today. Again, how you can do it. Open RCG website, then open book exam, MRCG part 2, expression of interest, and fill this form. It's very easy. It takes only 1 minute. Okay. So here we can have the exam in most of the countries. There are centers called person view center. It's computer center. For example, in Egypt, you will find in Cairo, Alexandria, and in Mansoura. You will find multiple centers in every city. So for sure, in your country, you will find multiple person view centers. Every center can have 5 computers, 6 dozen, maybe more, maybe less. Not big number. That's why still there is availability of seats. Okay. So the exam is computer-based. It's not paper-based anymore. And it's more better than being paperwork. So there is no chance that you will leave a question without an answer. And also you don't need to transfer answers from a paper to another one, from question sheet to answer sheet. No, it's computerized. You will read the question, you will submit the answer, then press next. So easy. So what are the fees of the exam? Okay, so these are the fees according to your band. The countries are divided according to band A, band B, band C. Band A band B, band C. For example, Egypt is band. It's according to the financial status and the standard of the country. So rich countries will be band A, intermediate B, poor countries band C, because it can be less in band C. Okay, so even from this hyperlink, you can press it so you can know your country under which band. So how the exam looks like? It's computer-based, made of 2 sessions. Every session, you have 100 questions. So session 1, 100 questions, and session 2, 100 questions. These 100 questions, 50 questions, EMQ, and the 50 questions single best answer. EMQ and single best answer. Okay. Every session of them will take 3 hours and 3 hours. So total 6 hours. And in between, there is 1 hour break. It's long, exhausting. Yes, especially EMQ questions are always challenging. Because in EMQ questions, you will find that every question has 20 options, 25 options, sometimes more, sometimes less. So very low risk that you will have the right answer by luck. So this type of question can differentiate did you study well, and you can know how to apply the guideline or not. Very low risk of having the right answer by luck. That's why more challenging. But we will be trained about how to solve it. So total 200 questions. After the exam ends, they take samples from the answer sheets, and from it they can make a curve so we can know what is the pass mark exam. Usually pass mark around 67%, 70, 72, so around 70%, according to the difficulty level of the exam. If the exam is difficult, okay, the pass score will be less. If the exam is easy, the pass score will be high. So don't bother yourself at all, is it easy or difficult? Okay, because if it's difficult, the pass score will be small. So concentrate upon how to prepare. Don't care for the level of difficulty of the exam. Just prepare well. Okay. So how many times you can attempt the exam? It depends. You are a trainee or not. Most of us, including me, we are not trainee. So no upper limit. Talking about part 2, there is no upper limit. What if I am a trainee 6 times, 6 times? Anybody here is a trainee? I am not in the training system. Can somebody write on the chat? Anybody here is a trainee? The trainee should pass within less than maximum 6 trials. If you are not trainee, no problem, you have unlimited number. But inshallah, we try to pass from the first try. Okay. Another thing, some doctors can pass part 2. Then they go to part 3 exam. Unfortunately, part 3 exam, you have only 4 trials. What if a doctor went to MRCG part 3 exam, he tried 4 times and he couldn't pass? Unfortunately, he will need to study part 2 again. Oh my God, it's very difficult. Okay, so we say, Alhamdulillah, I passed the part 2. Because part 3 is really easier, because it's practical and clinical skills or the knowledge. But if somebody couldn't pass in 4 trials in part 3, he will go again to study part 2. Oh my God, it's very difficult. So please, studying well part 2 will help you to pass also part 3. Because if you are going to have part 3 exam and you didn't study well for part 2, also you passed, you have a defect. You need to study again part 3 because part 3 has only 4 trials. You should be ready with all your syllabus for part 3, including having good knowledge from part. Okay, so how long you can wait after having MRCOG part 1 exam? It depends. You passed part 1 before 2013 or after 2013. Before 2013, maximum 10 years. After 2016, 7 years. And this is depending upon you are also in the training program or not. Because if you are in the training program, so you are in the rota of the training matrix. Usually, the training matrix from ST1 to ST7, it takes 7 years. With some doctors, it can take 8 years, maximum 9. Okay, so they can extend from 7 to 8, maximum 9. Okay, again, most of us not the training. So if you So the duration between part 1 and first trial for part 2 should be within 7 years or according to the rota if you are at trainee and you are overseas candidate, the duration is 10 years. And now because of the COVID pandemic, so year 20 and 21 are not counted. That's why we can say the duration now because of the pandemic for overseas doctor can be up to 12 years between having part 1 and your first trial to have part 2. If the duration between your part 1 and your first trial for having part 2 will be more than 12 years, unfortunately, you cannot have a seat for part 2 and you need to repeat again part 1 MRCOG. Another question? How to register for your course. I will talk about the course now, Dr. Faiza. Dr. Salma wants me to show again. Okay, I will show it now. Okay, walaikum salam, yes, doctor. Please, what's your question?
No, just I want you to repeat the screen that containing the step.
Okay, I was just reading the question. So asking about this one. Right? This one?
Yes, thank you.
Yeah, okay, thank you. So your next step is to do expression of interest, and I recommend you do it today. It's very easy, it takes a minute. But if you didn't do it before 13th of October, you cannot have the exam in January. Okay. And for Muslims, you have an advantage in January exam because in July exam, there is Ramadan about 2 months before or 3 months before the exam. But now you don't have Ramadan, so you have full time to study. Okay, so I gave part 2 courses since 2017. So far they are 7 years, and your course, this coming course starting this week will be course number 14 in part 2. Okay. So this was my first course in 2017. Okay, then I gave 2 courses every year, mashallah, all these doctors passed with my part 2 course. And if you find also my Facebook paper, my Facebook page, you will find many congratulations at the exam for the first exam. Okay, so what is our course made of? Okay, Dr. Sumaya asking, how we can deal with EMQ. You will be clever in solving EMQ when you read the question and you bear answer in your mind, then you look at the options. Then you will find your answer. You understand me? You will be able to solve EMQ well if you can answer without watching the options. You understand me? This comes only by good studying of the guidelines. Because, for example, if we have an EMQ about prolapse, he will give you multiple scenarios of prolapse. And every scenario, you need to choose an answer. And mostly every scenario has a different answer. So this needs deep studying of the guideline, not superficial studying. With superficial studying, it will be difficult. We need deep studying to understand how we can solve the multiple scenarios about endometrial hyperplasia, about prolapse, female genital mutilation, about any topic. This comes from deep studying, not just having a superficial eye. Okay? Because okay, so there is no chance of luck. Luck plays role only 4 to 5% in EMQ questions. At least 20%. Any problem with my internet connection? You can hear me well?
Yes, no
Yes.
problem.
Okay, so because in single best answer you have only 5 options, your chance of luck is 20%. But in EMQ, you can have around 25 options. So luck only 4%. So how we will prepare for the coming exam in January? Number 1, long course. It will be twice meetings. In this month, it will be on Saturday and Sunday. After that, it will be on mostly Saturday and Tuesday. But this month, because I am still in UK, I will have a long vacation starting from the middle of August. Until then, our meetings will be on Saturday and Sunday in my weekends. After that, it will be mostly Sunday and Tuesday. And I can take your voting about what will be the days after the middle of August. But now, only on Saturday and Sunday. So we will start from next week, Saturday and Sunday. Okay. From 22nd. 22nd of July. So 2 meetings every week, every meeting of them about 4 hours duration. For every meeting, I will explain some guidelines and some talk articles, and I will explain from my PowerPoint. After finishing the meeting, you can go to my website, you will find there the PowerPoint and the video recording, and also you will find questions and answers in the PowerPoint, and also you will find a quiz. So after studying the questions and answers from the PowerPoint, you will be able to open the quiz, solve the questions. The website will give you a score. See if you hit the pass mark or not. Okay. So twice weekly exams, which are the quizzes. And always I ask you that after solving every quiz, take a screenshot from your score and send it to me on WhatsApp. So I know that you are up to date and you are studying and solving well. The most important question I'm always asked, do we need to open the guidelines at all? Do we need to open talk articles? No. After finishing all my material, then you can think about others. Don't ask me about, can I open others and you didn't study the material yet. Okay, so we have priorities. Priority number 1, study all the lectures and all my PowerPoints. Then you can ask me if you have time. Then you can ask, can I study others? And I know if you study the material, you will not have time to ask about others because mostly there is no others. Very limited to find others. Okay, so your only source of studying will be my website. It's containing all my PowerPoints, all my videos. The video of today will be uploaded to the website. Then, inshallah, in December, there will be a crash course to summarize, collect the most important points, so we can get ready for it. So you will study from the website. Another very important question. Doctor, what if I was absent? I couldn't attend a live meeting because I have duty. And of course, this will happen. No problem. Next day, sometimes even in the same day, if you open the website, you will find the PowerPoint and the video record. So you will watch the video. I am now recording our meeting. It will be available on the website for recording. So I gave you no excuse. You will study. But of course, it's much better that you attend the live meeting. So after attending, you have a chance to ask questions, and you can ask me again to repeat explaining a point if it was not understood well. Okay. I don't repeat if the problem was your internet connection, or you have just come. No, I don't repeat. Because if I do like this, I will be in a vicious circle. I will stay all the meeting in the first 5 slides. I repeat if you hear it from me and it was not easy to be understood. Then I can repeat unlimited number of times. So what is our curriculum? And this is not only the curriculum, but in some of the topics. I will say them: systemic lupus, pregnancy, hemophilia, diabetes, DPA, early pregnancy, including miscarriage, ectopic, molar, unknown location, hypertension, and maternal collapse, small for gestational age, recurrent pregnancy loss, and we have just a very new green to guideline about RBL. This is the one we will study, inshallah. Cord prolapse, obstetric cholestasis, thrombocytopenia, RBCs, antibodies, and hemolytic disease of fetus and newborn. Cardiac diseases, post-pregnancy, and we have a recent book article about acute coronary syndrome in pregnancy. We will study, inshallah. Preterm labor, psychological problems post-pregnancy, and the role of perinatal mental health. Neurological disorders including epilepsy, stroke, breech presentation, ECV, nerve injuries, injury and oops, and GBS, which is infertility. Intrapartum care, instrumental delivery, cesarean section, vaginal birth after C-section, Ogilvie syndrome, venous thromboembolism, prophylactic and treatment, ovarian venous thrombosis, breast cancer in pregnancy, bronchial asthma, appendicitis in pregnancy, twins, skin eruption in pregnancy, renal problems in pregnancy, amniotic fluid problems, hemoglobinopathy like thalassemia and sickle cell, antepartum hemorrhage, placenta previa, morbidly absent placenta, postpartum, death, abortion care, reduced fetal cax, induction of labor, abdominal incisions, many other talks, antenatal care, teaching, thyroid problems with infertility, pregnancy, infertility, including talking about IVF, hyperstimulation, polycystic ovary syndrome, contraception, including all the contraceptions, and including United Kingdom medical eligibility. Female genital mutilation, it's our topic today, inshallah. Menopause and ovarian cyst, whatever ovarian cyst in adolescence, in the childbearing period, and post-menopausal. Gynae infections, obstetric infections, including viral bacterial infections. Pelvic organ prolapse, laparoscopy, urogyne, including continence, bladder pain syndrome, Fowler syndrome, and others, cystoscopy, endometriosis, irritable bowel disease, irritable bowel syndrome, and inflammatory bowel disease, and endometrial hyperplasia, cancer cervix, and cervical screening program, and ethics, obesity, endometrial cancer, complex social factors, hysteroscopy, abnormal feeding, sexual abuse, governance, vulval problems, whatever, malignancy or none, ovarian cancers, ergonomic laparoscopy, sepsis in pregnancy and postpartum, postmenopausal bleeding, statistics, and many other topics, and the list is always increasing because every 3 months we have a list of reviews coming from the Dog magazine. So it's expandable. You know, expandable movie, our curriculum is also expanded. After studying all of this and studying it well, ask me, doctor, I still have time. I need to study more. I will tell you how to study. Okay, but memorize by heart, study very well, all of this at the beginning. Then ask, I want to extend. I will tell you how to. Okay, but now you are talking about that you want to get the golden medal in the exam. Okay, and mashallah, you are a genius because our curriculum is more than 6,600 slides. After studying all of them well, ask me about how to expand them. Okay, of course, plus how many the last time? Yes, 3,000 questions and answers quizzes. After finishing all of that, ask me about more. Okay. I forgot. Also, there are some topics in the crash course, including revision of all what we said now, in addition to some small additional topics. Okay. Okay. So longer course, then crash course, quiz for every topic. I think it's more than need for the exam. Okay. And don't fall in the problems that I always see in some candidates. That at the beginning of the course, they ask, doctor, are you sure I don't want to open the guidelines? Are you sure I don't want to open the tools? Then at the end of the course, they didn't study the PowerPoint. So please don't do that. From the beginning, be regular. So the 2 topics or the 2 sessions we have per week, study them well. Don't delay your duty, because if you delay, it will accumulate. And we want, as we said, go to this exam, and we are preparing the best, not only for the exam, because we will use this knowledge in our practice, our thing, our. Okay, how my website looks like. When you open it, you will do login, and all doctors who subscribe to the course already within the previous days already, I think they have accounts, still very few, and you will be added to the site maybe today, inshallah. Okay, then you will open the courses you are involved in, and you will find January 2024 MRCOG Part 2 exam. Then you will open the list of the topics, and a good news for you all, from the first day, all the library is complete. So doctor, I know today we are the first day of the course, but I have a teaching session in my hospital about endometriosis. No problem, my friend. Open the course material, read endometriosis, no problem, and you can use it for your teaching session. Doctor, I want to know about cancer because one of my patients suspected ovarian cancer. No problem. although we are still at the beginning, but the library is complete. So from day one, you will have the full library that was recorded within the last 6 months with the previous group 13. Okay, but after we have day one, same day or next day, we remove the old video and upload the new one. We remove the old PowerPoint and upload the new one. But from day one, all curriculum is complete. Okay? Okay. So these are some screenshots from the website, from the quizzes. So you read the question, you take an answer, and you press next or complete. At the end, you will get a score to know what is your score. How many questions you got right, how many wrong, and always we are trying to improve our platform. Okay, some feedbacks from doctors all over the previous courses. Alhamdulillah, always the feedback that it was very useful, and alhamdulillah, I try to do the best to the doctors who are present in my course as much as I can. This was from a questionnaire, and this is a summary of, not the summary, this is a collection of the final comments about the course. Always I hear the word doctor. All my family knows you because they always find me opening the computer, listening to you, or opening computer and sitting in your session. All my family knows you. Of course, Dr. Mawahib, there are new guidelines. There is a very recent one about recurrent pregnancy loss. It's a green top guideline. And of course, in the last 6 months, there were 2 issues from the top magazine. Yes, I became already one of the family members for my candidates. So this was Dr. Ahmed has a question. Dr. Please, timetable for weekly 2 sessions. Okay. So, for the coming months, we will be on Saturday and Sunday, 1 p.m. UK time. Saturday and Sunday, 1 p.m. UK time. Okay, but from middle of August, it will be mostly Sunday and Tuesday, also 1 p.m. UK time. Okay, don't worry, I will send an email including this time. Dr. Hiba asking, can I start now joining the course while waiting for part 1 result or different weights? Okay. Another question, I am planning for July, but I want to start from now. Okay. Doctors want to start from now. They have 2 options. Either they can attend the current course and they can have good discount with the coming next course, which will be course number 15, or they can attend now and just do extension to the material for less. Okay, so you can have current course and also the next one with full discount, or the current course and just extend access to the material for reasonable fees for the next 6 months. because you are talking about 1 year plan. Okay. Okay, for the fees of the course, I think all of you filled the Google Drive form sent to you. Okay, you will receive an email containing, okay, all of you received emails, right? About the timing of the meeting today. All of you received emails? Which contains the link of the Zoom. The course for Jan, it started already today. And our next meeting will be 22nd of July. Okay, for the fees, you need to ask me personally because it's depending, Dr. Asma, upon if you had a course with me before or not, and in which country you work. Because doctors who had courses with me before, they have discount. The way you are going to start course for Jan, I answered, we started today. Our next session will be 22nd, then Saturday, Sunday until middle of August, then will be on Sunday and Tuesday. Dr. Ahmed asking, I do expression of interest. Email reply since February that overseas doctors and for second part in years for me up to excellent. You did this now? Is it enough or need another reply from them? Please screenshot to me the replies you sent. Okay. Dr. Mohib, I have access to long course material until September because of the COVID. They extended 7 years to 10 years. That's why I want you to send them an email so you can confirm that you have access. I have access to long course material until September. If I want to attend live session, okay, contact me personally to get back. If I'm planning to enter July, when session end in January, we start just after the exam. Okay, our colleagues who had the exam this month was about 6 days ago. We start immediately after the exam to start our group. Hi, doctor, if we attend part 1 this July and we hope to pass, we can be prepared for part 2. Multiple doctors asked for this question, so we need to find a smart option that you can join the course for only 1 month. Then either you tell us if you want to extend, okay, or unfortunately you need to return again to part 1. Okay. Is the timing of the online session negotiable, or it's fixed 1 p.m. UK time? It's fixed because if it's negotiable and we are, for example, 100 doctors, everyone will give me different timing from the other. So it's fixed. Okay. What can be negotiable? Maybe, not sure. About the days from middle of August. Okay. Any other question? You can open your mic if you want. Time of online session 1 p.m. How long? About 4 hours. No Friday, no. Until middle of August, Saturday and Sunday, because they are my weekends. Question bank. It's present. What about it? What about the question bank? You can study questions by 2 methods. In every PowerPoint, you have the questions and answers. And in the quizzes, you have the question You choose the answer, then you press submit. It will tell you is it right or wrong. They are enough. Okay, so after solving the 3,300 questions with their answers, and you solved them well, and you get score more than 90%, ask me, I want to expand. I want more questions. Where can I find? Deal? But finish at first the 3,300 questions present in my quizzes. Deal? So you are one of the genius persons. Welcome. Hello, doctor. If for any reason not completing session, can we return back to it? Yes. Every session is recorded and uploaded to the site. If you miss it, you couldn't attend. If you want to study more, the video is available until January exam. Until January exam. You are right that you are genius, right? Yes, you are right that you are genius. Okay, good. No, it's about you are genius. Okay. It's not logic that already you subscribe to a course containing this huge number of questions, and alhamdulillah, the answers are revised by me. So these are my answers. And you don't study them and go to pay to another source. Already you have one to subscribe. Okay. All material will be there before lectures. Yes, from day one. Doctors who subscribe to the course within the last week, did you try opening the course material? If you open it, you will find January 2024 course. You will find everything present, all the PowerPoint, all the videos. Okay. The date of next lecture, 22nd of July. Saturday, Sunday, Saturday, Sunday. Saturday, yes. Time of online session, how many hours? 4. Range of hour per one, 4 hours. Usually we take 1 hour and a half, then break about 10 minutes. Total around 4 to 5 hours. Could you tell us name of the topic? Yes, there is a list for the topics. There is a PDF containing a list of topics, so you can prepare. And I don't recommend that you prepare before the meeting. I want that you study after them. Okay, because in the session, you will find it was easier than when you read it. So just attend the meeting, even without any previous knowledge. After the meeting, study the PowerPoint or the video. What topic you will discuss today? Female genital mutilation. Okay. Okay. So we will take a break 10 minutes. Then the same link will be working. I will not close it. Just after 10 minutes, I will share again my screen. So we start about our medical topic today, which is okay. Any question before we leave? Don't leave. Same link is still working. I will just mute my mic, stop my camera, and stop sharing my screen. Okay. 10 minutes, and we return back. Thank you. Bye. So our scientific topic today will talk about female genital mutilation, which is called female circumcision or female cutting in many countries. But its UK name is female genital mutilation. And The word mutilation means causing disfigurement. That's why it's considered a crime. Okay. So female genital mutilation is considered a crime in UK. So what is the meaning of mutilation? It's a cutting to the genitalia without any medical indication. And it has 4 types. Type 1, cutting to the clitoris. Type 2, cutting to the labia. Type 3, it's called Sudanese type. In Sudanese type, they cut from the labia on the right side and from the left side, so the labia will fuse together in the midline to be like a transverse septum. So this is type 3. Type 3, any other form like cutting, any injury, breaking, it's type 4. Which one is more common? Type 2 is more common. So the most common one that you cut to the labia. So this one is the most common, but the most dangerous, type 3. Another name for type 3, it's called Sudanese type. Why type 3 is the most dangerous? Because it will lead to fusion in the midline. So it will make sexual function difficult. It will make even urination difficult. It will make much disfigurement. Even at the obstetric level, it will make the delivery itself even difficult. So it will lead to problems in first stage of labor and in second stage of labor. That's why the baby can suffer during the delivery because there will be dystocia. Dystocia will increase the risk of hypoxia and also other problems during pregnancy. That this patient, unfortunately, because usually this procedure is done with non-sterilized instruments and usually with non-doctors or non-medical personnel, it can lead to transmission of infections like hepatitis B, hepatitis C, HIV, and other infections. So, more infection, obstetric problems, sexual problems, psychological problems like post-traumatic stress disorder, which will lead to an anxiety and depression, sometimes even committing suicide. That's why it's criminalized by the UK law. And if you know that a girl is mutilated, so there is a crime happened. That's why. So whenever you find a patient below 18 years old, which is called a child because she is below 18, and she is mutilated, and you are sure, you should tell police because police will do investigations to see why this child was mutilated and who was responsible. Because all the parents, they have the duty to protect their children. Okay, so this is the word mutilation and what are the 4 types and what we do. If in the clinic I find a girl below 18 years old is mutilated, I should inform the police within 1 month. What if she is below 18, came to the clinic, and there is recent mutilation? The wound is still fresh. Immediate informing police, not within 1 month. Why? There is a very recent crime. We need to start investigation. Even the police can take evidence from the wound, so we can know who was the criminal who did this crime. The crime is not only in doing mutilation. The crime also to the parents because they couldn't protect their child. Also the child, if anybody helped or assisted in doing this crime. Okay, as we see, it's a big problem which can affect these young girls. Okay, exam question. What is the highest country of prevalence of female genital mutilation? The answer is Somalia. Okay, another question. What is the most common type? Type 2. What is the most dangerous type? Type 3. Okay, type 3 needs a specific procedure, which is called defibulation. Defibulation. Type 3 itself is called infibulation. So this septum artificial septum is called infibulation. This septum can make urination difficult because here inside there is a urethral opening, and there can be small opening here for intercourse, or even no opening at all. It can be like complete septum. Okay, so this septum needs to be opened by a procedure called defibulation. Defibulation. It's a cutting to the septum, and then we sew the edges so it doesn't reunion again. This defibulation can be done before having first sexual intercourse to make intercourse easy. If during pregnancy, we can cut it antenatal in usually around 20 weeks pregnancy. If not done, it can be done during labor, the first stage of labor. If not done, we can do it in second stage of labor. Okay, how we can do it? If local anesthesia, then you need to cut it. How to cut? You can cut either by scissor or by knife. But be careful. If you are in second stage of labor, you cannot use knife because you may cut the head of the baby. So in second stage of labor, only using scissors after giving local anesthesia. Okay, what if the patient refusing this defibulation? I will do it or not? Yes or no? Can you answer on the chat? If the patient refusing defibulation, I will do it or not? You can answer on the chat. Yes or no? Dr. Nina said no. Others said yes. Others said no. The answer is no. I cannot do something against the patient will. I cannot catch her and enforcing her, then I do the cutting. Of course not. This is her choice. But I will inform him about the implications and the complications of having this infibulation. Okay? Even if a harm happened to the baby during birth, the woman's decision, not my decision. We say the baby in utero has no rights. Once the baby is born, has full rights. Okay? I will tell her this can make the delivery difficult, increases the risk of cesarean section, increasing the risk of needing episiotomy, increasing postpartum hemorrhage, fetal hypoxia, abnormal CTG, postpartum hemorrhage, many complications. Refusing, we respect your wishes. Okay? We cannot enforce her to do this defibulation. Okay, if the patient accepted that we do defibulation, so we did it, and we opened the septum, and the patient delivered vaginally, and she is asking that we suture again the septum to do refibulation again. Can we accept doing that? Refibulation, of course not. We cannot do this. Why? It's a crime. Mutilation is a crime. So we do defibulation, but we don't do refibulation. Okay? Important recall question. What if there is a bleeding point in this septum? I will suture the bleeding point, but I will not reunion the septum. I will suture the bleeding point. If no bleeding, no suture. What about if there is episiotomy? Of course, I will close the episiotomy as usual. But I will not do reunion to this septum. Okay, clear? Yeah. Okay. Do we ask about mutilation for all women? Yes. How we ask about it? There is a routine question we ask for all women during the pregnancy at the booking visit. Booking visit is the first antenatal visit during the pregnancy, usually done before week number 10. We ask them, did you have any surgery before in your tummy or pelvis or down below? down below here means the area of the genitalia. If she said yes, I will ask more details. What was it? Can I see it? If you find mutilation, you need to take permission to take photos of this mutilation and document it to the documentation. And when you know that your patient is mutilated, you need to report to HSCIC. This organization is collecting statistics about mutilation. So you will say, I have a patient, her name is so and so, she has mutilation type 2, for example. You will write her name? Yes. But is this breaking to the confidentiality? It's important to say the name. Why? Because if I see the patient today, I did documentation and reporting to HSCIC. After a week, she was seen by another colleague who will see the mutilation. He will report to HSCIC also. After a month, another doctor will report. So now she is counted as 3 patients. That's why we should mention the name. Why? To avoid duplication of data. And tell her, okay, this is not breaking the confidentiality. It's just important to avoid duplication of data. Okay. So when you don't say my name, you are doing anonymization. Anonymization. When you don't say, when I say somebody is asking a question on the chat, I did now anonymization. But if I say Dr. Rewa is asking a question on the chat, so now I didn't do anonymization. You understand me? So if I say somebody is asking a question, I did anonymization. But if I say Muhammad is asking a question, I did now no anonymization. I said his name. And when we report to HSCIC, which is one of the social services collecting data about statistics of mutilation, I do no anonymization. What does it mean? I say the name of the patient in the report to avoid duplication of data. Okay? Okay, I have a question to you. You have a patient who is 17 years old. Okay, she's pregnant. With examination, you find she has mutilation type 2. And I asked you, what you are going to do? Report to HSCIC without anonymization, or report to police within 1 month. Which one is more important? HSCIC or police? My patient is 17 years old. Police is more important. You're right. Police here is more important. Okay. What if the age is 18? Here, no need for police. Just I will report to HSCIC without anonymization to collect the data for statistical purposes. Here? Okay. So in children, police is most important. Okay. What if 17 years old, pregnant, mutilated, and the wound looks to be recent? Urgent police. Urgent police. Not within a month. It's urgent. Because there is a crime, recent crime. They can collect evidence. They need to catch a criminal because it's a recent wound. Okay? Okay. After delivery, we gave the mother what's called a red book. A red book of the baby. It is a book in where she can find data about the vaccination, about the growth of the newborn, about the feeding, also containing data about the mother herself. Among these data, if the woman is mutilated or not. So in all women, whatever the baby is boy or girl, we document to the red book if the mother is mutilated or not. That's why in the exam, when he asked about the woman delivered and the baby is boy, what is the most important thing to do? Just document in the report. Is this baby at risk? No, this baby is a boy. But what if the newborn is a girl? So here we have mutilated mother and the baby is girl. The red book here is not the most important thing. The most important thing here, this woman, this baby is at risk of being mutilated later or not. So here the midwife will do risk assessment. If this baby at real danger, we can inform the police. Okay, but if low risk, just to report child safeguard. What does it mean? If the family say, we are going to mutilate our child, here, police is more important. If they say, we know that mutilation is something is not good and we are not planning to do it, it was just one of the traditions in our countries, but we are not going to do it. So just child safeguarding. Clear? Clear? Okay? Okay. So you need to report to police if the patient is below 18 years old and mutilated. All the mutilation, report within 1 month to police. Recent mutilation, report urgently to police. After delivery, if the baby is girl and in real risk, they are planning to mutilate, inform police. Low risk, child safeguard. Baby is boy, just to document into the report. Okay, we don't have a problem with male circumcision at all. Okay, and even our midwives are trained how to deal with Muslim moms, and our midwives are trained that Muslims will do circumcision to the boy after delivery. Also, they are trained about many of the Muslim beliefs. Okay, like about cutting the hair after 1 week and giving gold to poor people with the same amount. Okay, they are trained about all of that. And they are trained that you like to be called Abu Muhammad if you have a boy called Muhammad. They are trained about it. So we don't have any problem with male circumcision. Our problem with female mutilation. Okay? Okay. I have a question, but okay. Okay. So let's start reading this. So we have 4 types of mutilation. We said type 2 is the most common and type 3 is the most dangerous. Type 3, which contains infibulation, which needs defibulation, and they never accept refibulation. Type 4, any minor cut, incision, piercing, cauterization, anything else. Type 1, clitoris. Type 2, labia, plus or minus clitoris. Type 3, infibulation. Type 4, any other thing, cutting, piercing. And Somalia has the highest prevalence, 98%. Although the criminalization of FGM, still 1.5% of newborn girls in UK, they have mutilation. Although it's criminalized. But because of too many immigrants from African countries and so on, they still do mutilation. But it's a crime. Okay. Complications. Complications can be during the mutilation itself or can be later on. So bleeding, urine retention, swelling, scarring, neuroma, UTI, urethral damage, usually done with non-sterile instruments and usually done with non-medical personnel. So more and more complications. Dyspareunia, no intercourse at all, less sexual satisfaction, And this is an important point. That's why psychological referral is important. And also they can be referred to psychosexual if they have sexual dysfunction. Sexual dysfunction will need psychosexual care because you have many problems during it for intercourse, like lack of desire, lack of satisfaction, okay, no orgasm. This needs psychosexual referral if one of these problems is present. Psychological problems like flashback. The patient will always remember what happened and will remember this black day and will feel sad and will cry. This is called flashbacks. And anxiety, post-traumatic stress disorder. Again, she will remember what happened. Even self-harm or committing suicide is one of the complications. Okay, problems during delivery because of the scar of the perineum or because of the infibulation, which is type 3. So more C-section, more baby problems, even the baby may die during delivery because of the dystocia. Chronic pelvic pain, difficulty in passing urine because of the scar and the disfigurement. Renal problems because of current UTI and retention. Reproductive system damage. Infibulation cysts in the infibulation itself. Fistula. Pregnancy complications, sexual, psychological, drug abuse because of the anxiety and depression and post-traumatic stress disorder. They may go to drug abuse. So many problems. That's why with all these complications, we say if a pregnant patient has female genital mutilation, in the first pregnancy, it should be consultant. Why? How this is different from the routine? Routine care to pregnant women that she will have midwifery care by the midwife or by the GP, usually midwife. But if this is the first pregnancy after mutilation, it needs to be consultant. Okay. When she was preemie, she had consultant care, she delivered safely without complications. What about pregnancy number 2? It can be midwifery led, but pregnancy number 1 must be consultant. Okay, clear? So she will be followed by a consultant. After first pregnancy, be midwifery led. Okay, so female genital mutilation is a crime. Illegal. Illegal to help. Illegal to assist. What is the meaning of mutilation? Cutting of the genitalia without physical problems or without having mental disease. For example, doctor, I am a child, okay, and I was born with long patulous labia. I am not happy with it. It's leading to fraction when I walk. We can do cutting or not? What do you think? Yes, we can. Why? She has a problem. She is physically not normal. You understand me? When you examined her, yes, you found long patulous labia leading to fraction. Yes, the age of this procedure after puberty. Okay, but after puberty does not mean after 18. You understand me? So it can be done only if there is physical indication. What is the physical indication here? Abnormal labia. Abnormal labia. Okay? Okay. But at first we counsel them that the labia is not something with fixed shape and fixed size for all women. Normally there is difference. Sometimes even the right side is not same like left side. So we need reassurance at the beginning. But really some children, they have abnormal long labia. Okay. So here we need to assess case by case. Okay. Also infibulation. Sorry, defibulation. It's a surgical cut to the labia. Is it a crime? No, defibrillation, not infibulation. Defibrillation is medically, it's not a crime. Clear? Okay. Okay. So a baby is delivered with congenital adrenal hyperplasia and long clitoris. We can cut this clitoris or not? Congenitally abnormal long clitoris. Deformity. To be removed or not? Yes, it can be removed. Okay. A patient had female mutilation type 3. It's indicated to have defibrillation. Okay. Congenital anomaly in the labia and very long patulus affecting quality of life. Yes, it can be removed. But the routine procedure that is done in some countries build upon maybe religious or social habits, this is a crime. Okay? Yes. Okay. So don't arrange, don't help, don't assist, don't organize, and of course don't do. It's offense if the parents could not protect their female child. That's why if you find a child below 18 is mutilated and you are sure, report to police within 1 month. Better next day, but within 1 month still okay. But if 1 month passed and you didn't report, you will be asked why you didn't report. 1 month passed. Ideally, report next day. Okay? Never do re-infibulation. Please don't be confused between infibulation, which is mutilation type 3, defibrillation, which is opening of septum to facilitate intercourse or delivery, refibulation, to reunion this septum again after delivery, which is a crime. Okay? Infibulation, defibrillation, refibulation. 1, 2, 3. Number 1 is crime. Number 2 is medical procedure. Number 3 also is a crime. If there is bleeding, let's say these are the two labia, Dr. Hannah, and there is bleeding from the right labia. Okay, I will suture the bleeding point. But will I do suturing to both of them together? Refibulation? Will I do like this? Of course not. Okay? So please suture here. Okay, anyway. You understand my point? So if there is bleeding from this point, I will suture this point. But I will not collect the two sides together. Clear? Because the patient will ask you, would you please regain my infibulation again? I am sorry, I can't. Why? It's a crime. Okay? Here? Okay. So when FGM is identified, as we said, age below 18, police is the most important thing. What if my patient is an adult? The most important thing is reporting to HSIC, Health and Social Care Information Center. They collect the data about mutilation. And please mention the name of the patient in the report. Why? To avoid duplication of data. So it's called without anonymization. I want to ask you a question. I will say 2 words and you tell me these 2 words are the same or not. Okay? The 2 words without anonymization, with no anonymization, are they the same or not? Without anonymization, with no anonymization, are they the same? Of course, they are the same. Because in the exam, because in the guideline, we are used to say without anonymization. But in the exam, you can find with no anonymization. It's the same. Okay? Okay. Please, this, I will mention the name, yes. Why? Not to break the confidentiality. It's just to avoid duplication of that. Because I will report and you will report. If we didn't say the name, this patient will be counted as 2 patients, not only 1. And this will give false statistics. Okay, and you have to tell the patient that in the reporting, I will mention your name, but this is not to break the confidentiality, just to avoid duplication of data.
So we should mention the name, right?
Yes, yes. To avoid duplication of data.
Duplication of yes.
Because this patient throughout her life will be seen by hundreds of doctors. If everyone reported her without saying the name, we will count her as 500 patients. She's only 1. Okay. Okay. So, what is this? Anonymization. Okay, on the left side, the red circle, this is anonymization. While this, without anonymization. We know this person, but this photo on the left, we don't know who is that. We did anonymization. So anonymous means without name, not able to be identified. Okay? And tell her this is not breaking your confidentiality. Okay, it's just to avoid duplication of data. So nobody will call you, nobody will tell you, will ask you. No, it's just to avoid duplication. Please, if you have a child and you are sure that she had mutilation, report to police within 1 month, ideally within the next day. But if you are just suspecting, don't call the police on suspicion. Okay? Otherwise, they will receive many false notifications. So if suspecting, just refer to social services. Just social services. But if you are sure, police within a month. I am sure and the wound is fresh, recent wound, it's urgent reporting to police. Okay? Okay. And after delivery already, we have to document into the red book whatever, if the mother is related or not, we should document into the red book. The red book, as we said, is the book given to all women after delivery, which will include data about the baby, the vaccination schedule, and the growth, and so on. It's like the one we gave to the newborn in Egypt. In Egypt, we gave blue one for boys and pink one for girls. Here it's red for all. Okay? Okay. Referral. Don't forget, psychological referral is important. Okay, and psychosexual if the patient has sexual problems. Urogyne if urogyne problems. Infertility if the patient is infertile. Many complications such a patient can have. Okay, so if a patient had female genital mutilation type 1, what was type 1? Type 1 was cutting to the clitoris. So her clitoris is cut, it was removed. And she's asking to have a surgical procedure so we can augment this clitoris to make it to look more larger, more taller. This procedure is called clitoral reconstruction. Clitoral reconstruction is not allowed in UK. Okay, it's abandoned procedure. not to be done. Never do clitoral reconstruction. Why? We believe its outcome is not good and it's complicated procedure without benefit. So don't do clitoral reconstruction. So if a patient asks, doctor, I had female genital mutilation type 1 and I want clitoral reconstruction, choose one of two options. Refuse clitoral, she is telling you also I have lack of sexual desire. So what you will do? Option number 1, do clitoral reconstruction. Option number 2, don't do clitoral reconstruction. Option number 3, psychosexual therapy. What you will do? Do, not do, psychosexual. Of course, I will refuse clitoral reconstruction, but did you solve her problem? No, she's still suffering. So you have to refer to psychosexual. So of course I will refer, but this is not enough. She needs psychosexual repair. Okay? Because she has
And
sexual
we will not do reconstruction?
We will not do it.
Why?
Clitoral reconstruction is abandoned in UK. It's not done.
Oh, okay.
Okay, because we believe it's purposeless procedure.
Not give result يعني?
It doesn't give results. It can lead to more disfigurement. So it's not accepted in UK.
Okay. So
Okay.
only referral to psychosexual.
Yes. If the same patient, if he is asking about a patient with type 1 mutilation, she doesn't have sexual problems, here, yes, here refusal of the procedure is enough. Because she doesn't have any sexual response. Right? Okay?
Yes, okay.
Okay. So this is the procedure of clitoral reconstruction, which its target is to augment or enlarge the clitoris. It's abandoned, not to be done. We don't do it. Okay? Not to be done. Don't accept. But if the patient has symptoms, please refer to psychosexual. She can have treatment for her sexual response. Okay. Please, in taking history, allow part of the history to be in with a family member and the part of the counseling even without family member. Sometimes the patient wants to tell you that she is mutilated, but she is shy because her partner is with her. So you can give a chance of the discussion to be in private. Okay, same point is also present if we need to know if the patient is exposed to any form of domestic violence. In the toilet, in the maternity department, you will find in the door of the toilet, in the inner part of the door, you will find a poster saying, if you are exposed to any domestic violence, if you want to have a private consultation with a doctor, please take this number. And in some maternities, okay, you can find a sticker, the patient. When she's asked to get a urine sample, if she take a sticker and put it at the bottom of the cup of the urine sample and gave it to us, she put a sticker. She wants to be counseled in private. There is something she wants to see in private to us. You understand me? So there should be some policies in the department so we can know if the patient wants to speak in private. Whatever about domestic violence or about something private like FGM, she may refuse to talk about it in front of the partner. Okay? Okay. For example, here we have a project called the Paragon. You will find the posters everywhere in the hospital, even in the toilet. So the patient can contact the Paragon if he's exposed to domestic violence. Okay, and this trick about the sticker if she wants to speak about FGM or even domestic violence. So we can allow part to be in private, but please, in private, doesn't mean you and the patient alone. It means you, the patient, and a chaperone. Okay? Okay. There must be chaperone always. Chaperone in Arabic means mahram. Mahram. Usually, chaperone is a nurse. Okay, so don't be alone with the patient, even if you are a female and the patient is a female. Okay? Chaperone is needed if you will do vaginal examination, even abdominal examination, even breast, any examination. Take a chaperone. Okay, ask a nurse or midwife to be standing with you. And you can ask the nurse, please, can you come to be as a chaperone with me? And already in the hospitals, posters everywhere talking about chaperone and importance. I will send you on the group one of these posters about importance of chaperone to be available, even if you and the patient are of the same gender. Okay? Because now having same gender does not mean that there is no sexual harassment. Okay? Okay. Are you sure that the patient is a female? This is another issue. Okay, so in antenatal care, at booking, we will ask the screening question. Okay, if the patient is positive, we will examine, document, report to HSCIC. If she is a child, report to police within 1 month. If the wound is fresh, report urgent to police. And FGM is an indication to screen for Hep C. Screening for Hep C is not routine, except for some groups, including FGM individuals. So we screen for syphilis for all, hepatitis B for all, but hepatitis C in some groups, including FGM. Okay. Defibrillation. To open this septum in type C mutilation. It can be done before first sexual intercourse, before pregnancy, during pregnancy around 20 weeks, or in first stage of labor, or in second stage before crowning. Before crowning, not at crowning. Before crowning. Before crowning. Because in the exam, he can ask you, a patient is pregnant. When you want to do this defibrillation, at 20 weeks gestation, or second stage at crowning. Option 2 here is wrong, because we want in second stage before crowning. So here's the only right one. Continue, 20 weeks. And we have a talk article about FGM. Talk article said 13 to 20. So we agree upon 20 weeks. What if the patient delivered by C-section? We can do it after C-section. Why you do? Already she delivered by C-section. We do it because it's not only affecting the delivery. Okay, it's affecting sexual life, leading to urine problems, urine retention, urine infection. Okay, many problems can occur. We don't add epinephrine to the area of the genitalia during giving local anesthesia because the vessels here are end arteries. End arteries. So if you do it, you give vasoconstrictor, it can lead to gangrene, a vascular necrosis. Okay? So don't give local anesthetic with vasoconstrictor. So in episiotomy, do you add vasoconstrictor? No. It's plain lidocaine. Okay? Okay. Dr. Rua asking, can she do it before marriage? Yes. We said even before first sexual intercourse. Even before first sexual intercourse. Okay? Okay. During delivery, as we said, take care at risk of many complications. And we can do defibrillation, whatever it's the first stage of labor, or in second stage before crowning. In second stage, don't use knife, use scissors, so you avoid injury of the baby. Group and save, IV access. Why? There is risk of postpartum hemorrhage. What is the meaning of group and save versus cross-matching? Can somebody say? What is the difference between group and save versus cross-matching? Somebody can say? The difference between group and save versus cross-matching. Excellent, Dr. Hannah or Hannah. Cross-matching, they will take sample from the blood of the patients and they will cross-match it with 1 or 2 bags or more if you ask for more. Sometimes you ask 4 bags of bacteria. Usually you ask for 2. So we know that there is no reaction and this blood is ready to the patient once it's required. Okay? Okay. So this patient just group and save. So the blood bank knows what is the blood group of the patient, and the blood bank will tell you, yes, I have bagged RBCs of the same blood group. Do you want me to do cross-matching? No. But if I need, I will tell you. Cross-matching takes 1 hour to be done. Okay, that's why in situation of severe bleeding, you can give the blood even without being cross-matching. Because cross-matching in the blood bank will take 1 hour. You don't have luxury of giving 1 hour more. You need urgent. So here, full blood count, group and save. Okay, doctor, what if my patient already has already high risk because of other reasons for postpartum hemorrhage, thrombocytopenia, for example? Here, cross-match. Not enough to do preventive. Okay? Okay. Okay. Can I ask you? A patient is telling you, I was mutilated as a child. You examined her. You didn't find evidence of mutilation. So, what is this? No mutilation or mutilation but certain type? There is no physical evidence. Is there any type of mutilation that you may find no physical evidence by examination? Type 4 can leave no evidence. Because type 4 can be just breaking by a needle. This is mutilation type 4. It can leave no evidence. Okay? So I believe the patient that she was mutilated, but this is type 4. Just breaking, okay, can be minor cutting, can leave no evidence. Okay. So how the fibrillation can be done? Okay, so this is in fibrillation. We will give local anesthetic. Okay, then we cut this septum. You can cut whatever using scissor or using knife. But please, if we are in second stage of labor before crowning, don't use knife because you may cut the head of the baby. So use scissors. You can protect the head of the baby. Then you do sewing to the edges so they don't heal again in the midline to avoid reunion. So this is the fibrillation. Okay, when it can be done before first sex, before pregnancy, pregnancy around 20 weeks or 30, 20 according to the dog, first stage of labor, second stage before crowning, or after C-section. All of them are good timings. But the sooner, the better. So she is pregnant now at booking. So I will choose 20 weeks for first or second stage of labor, 20 weeks. Yes. Okay, the sooner, the better. Okay. As we said, in all patients, we take history, including asking about, did you have any surgery in your tummy or pelvis or down below? If she said no, okay, that's all right. If she said yes, so do you mean that there is cut in the genitalia? If she said yes, and she is below 18, we have to report the police within 1 month. Police within 1 month. Okay, and the police will initiate multi-agency safeguard. What if the patient more than 18? There is no rule for police. Okay, no rule for police, but we will report to HSCIC without anonymization. We will later know the gender of the baby, and if the baby is boy at delivery, just report and mention in the report that she is activated. But if the newborn is a girl, inform police if there is high risk, or inform child safeguarding if there is low risk. Okay, the effect of mutilation during the pregnancy, antenatal, intrapartum, postpartum. Okay, you can open your mics to answer if you want. First pregnancy after mutilation will be midwifery led or consultant led?
First pregnancy with consultant.
Yes, that's right. Okay, she had already her first pregnancy and delivered without complication. The coming pregnancies will be
Midwifery.
midwifery led. Excellent. Okay. Which infection should be screened for in a patient with FGM in addition to the routine screening?
Hepatitis C.
Hep C, you're right. In addition to the routine, so syphilis, hepatitis B, HIV, but hepatitis C, it's not routine for other women, but here it's routine. Okay?
Yes.
Okay. So, can we do defibrillation?
No.
Yes.
Yes.
Refibrillation or
Yes.
defibrillation?
We can.
Yes, we
Defibrillation,
can.
yes.
Mm.
Okay, can we do infibulation?
No.
No, it's a crime. Can we do refibrillation?
No.
No.
No, it's also a crime. Can we do clitoral reconstruction?
No.
No.
It is obsolete. Abandoned.
Abandoned, not to be done.
Yeah.
All right. Okay, a girl below 18 years old and mutilated. What is the most important thing?
Inform police within 1 month.
Police within 1 month. Better to be
Yeah.
next day. Okay, what if the wound is fresh?
Immediately.
Immediate
Urgent. Yes.
Reporting to police, yes. Okay, to what authority we report if an adult is mutilated?
Our SCIC.
HS?
HSC. Yeah.
I will
Yeah.
see the name of the patient or not?
Yes.
Without
Yes, I will say.
anonymization. Yes. Yeah.
So with no anonymization. So
Yeah.
I should say the name of the patient. Okay. Which week in pregnancy is the best for defibrillation?
20 weeks.
From
Around-
13 to 22.
Around 20 weeks.
Mm.
According to the TOG, 13-20. According to the guideline, 20 weeks. Okay. Can I do defibrillation in second stage of labor with knife?
No.
No. Because you may cut until you reach to the bone of the skull. Use scissor. Use scissor. Okay. Okay. What is the country with highest prevalence of FGM?
Somalia.
Somalia. Which type is the most dangerous?
3.
3. Which type is the most common?
2.
2.
2. How much of newborn girls in UK are mutilated?
1.5.
1.5%.
Yeah.
Okay.
There is mutilation in UK.
Yeah, from
Yes.
overseas.
Either done here or they take the child to their original country to be mutilated there, then they come back after having mutilation. This is also a crime. When they come here, they can be prosecuted.
Mm.
Okay,
Because it is a crime.
it doesn't it doesn't go under cover of legality, right?
There is no legality for FGM as long as it's not for congenital anomaly or physical abnormality in the girl.
Okay.
Okay.
Yes.
Okay. So can I do it for a patient born with congenital hyperplasia and she has enlarged big clitoris? Of course. For clitoromegaly, of course, it's not for
Yes,
the
we
mutilation.
can do, but only when she become adult, right? Only when she become
It
adult, not
depends.
in childhood.
It depends. It depends.
It depends.
Because sometimes she can be born with very big clitoromegaly. Okay, so
we
it
will not
depends.
wait. So we will not wait until she become adult.
Usually, if we can wait, we wait until after puberty. Why? Because the size of these organs change around the time of puberty. Until we reach the puberty, this is now the actual size.
So
Okay.
we have to wait until puberty, or we do.
So I will ask you a question. Okay, a girl in first grade in the school, she was born with clitoromegaly, and her clitoris is this length. What you will do?
مش عارف يعني I will do
So she will go to the school with
normal.
That's why I will say it's individualized.
Individualized.
Okay,
So
but if you-
يعني no rule to prevent utilize يعني no rule to prevent this operation while childhood in children يعني.
This is
No
not
rule in
called
UK.
mutilation now. It's now called, okay, it's cosmetic or corrective surgery.
Okay.
Okay,
Anyhow,
if
it's not prevented. It's not prevented. Yeah, I mean it's not prevented. That's my question. It's not prevented.
Okay,
It's
you are now
individualized.
correcting anomaly for treating a disease.
Okay.
Okay, the best timing is after timing of puberty. Okay,
Yes.
but sometimes, okay, the deformity is really affecting the quality of life of the child. Okay, so if a girl, and we are talking now about very rare scenarios, about a child in the school and she has very long clitoris, affect the quality of life. And you will tell her we will wait until age of 15 or 16, and she is still now 8 years.
No, it's a very long time.
So let's not to put rule for this thing because it's individualized. Okay, but as we said, if FGM for no medical indication, it's a crime.
Okay.
If there is medical indication, it will not be called FGM. Okay? You know what is the meaning of the word mutilation in Arabic? تشويه.
تشويه, yes.
تشويه. Okay, so if it's done for religious ideas or for specific traditions, it's called the mutilation. Okay, but if there is disease, congenital anomaly, yes, here now there is medical and surgical indication, not mutilation. Okay.
Yes.
Okay. So here, what is 1.5? 1.5%. Yes. Okay.
In UK.
In UK, yes. Although all this criminalization of the procedure still being done. Okay, you cannot prevent a crime 100%. So here we finished our topic today, and what is required from the members of the course. You will find in the PowerPoint many questions, including mostly all the records about this topic. You will find every question with its answer, and sometimes I put even justification for the answer. Then you solve the quiz about FGM and send to my WhatsApp a screenshot of your score. I need at least 90% score. Okay? So when will be our meeting? This meeting as orientation session will be repeated again for doctors who couldn't attend today, will be after tomorrow. Then we start our regular meetings, inshallah, on 22nd, after 11 days. Every Sunday, every Saturday and Sunday. Until middle of August. At this time, I will be back to Egypt. I will be in a longer vacation. Okay, then our meetings will be every Sunday and Tuesday, inshallah. All members will receive emails about the time of them. Okay, thanks so much. I was happy that.
Thank you so much.
In the yes.
Excuse me, Dr. OSAMA. Thank you very much for your very interesting session and topics. Just I need to say, we need to start to organize for the course or to pay for the course before we can start to solve the question for today's session, or when you open the course registration.
Yes, doctors who subscribed already, they have access to my website. Okay, and if they subscribe today, they will have access starting from today. It will be including all the full library, including all the recordings within the last 6 months. Today, inshallah, we will remove the old video about FGM and upload the video of today. So now we understand our method.
That means we can apply for the course and pay for fees, all this done today or during these days before the first session on 22, the second session?
Okay, again, the orientation session will be repeated again after tomorrow. And the regular meetings of the course will start after 11 days. You remind me of a very important thing. For the fees of the course. Okay, there was already a discount offer, 25%. This offer should have ended today. Okay, 25% discount of the fees covering access to the website until January 2024, including access to all the PowerPoints, all the videos which are undownloadable, and attending all live meetings, WhatsApp group, all the quizzes, including 3,300 questions, and including the crash course in December. Okay, all this package has 25% discount. Okay, and this discount is extended 1 week more. So couldn't subscribe yet, they still have a chance, 1 week more extension to the offer of 25% discount for the package. Okay, doctors who attended the same course with me before, they have discount more than 25%. Usually it's 30%. Okay, to my same WhatsApp is managed also with the managers of the company, so they can reply to you about having links for payment of the course, which can be by Visa. You can pay by Visa if you want. Okay, just contact on WhatsApp number, so you may receive the link for Visa payment, or you may have the bank account, you can pay by bank transaction.
Sorry, doctor, we can do download for material or
Undownloadable.
undownloadable. Okay. Okay.
Okay, and I was asked before about studying from books. I prefer that you download the guideline and study it better than studying from books. Why? If you had a book, just you bought this book 1 month ago, and you are going to study from it, is this book the most recent up-to-date? No. Why? In this last month, a genital guideline was published about recurrent pregnancy loss. So what you will study about recurrent pregnancy loss will be all the data. If you answer using it in the exam, it will be wrong answers. So I prefer my website. It's up to date until today, except RBL lecture. Within a week, it will be updated. Next topic, I will send to all members, inshallah, a timetable about the lecture.
You have any WhatsApp group or Telegram group to announce about this session before the starting? Any discussion, any question in the group, or you didn't have?
Okay, there is already WhatsApp group for all the course members.
Okay.
Yeah. Any question? We finished our meeting today, alhamdulillah. And again, thanks much for all your attendance and best wishes for all in this journey to prepare and pass MRCOG Part 2, which can be one of the most important exams in your life. After this exam, you will feel so much relief. You are now standing on a fixed land, and just you need to have another step for Part 3, which is considered easier if you are strong in Part 2. Okay, thank you so much. See you in the coming meetings, inshallah, and Assalamu alaikum. Bye-bye.
Bye.